Department at Future Institute of Engineering and Management. Once again, I welcome you all to the fifth day of AICTE approved online faculty development program on the theme MedTech Challenges and Opportunities under the Make in India framework. Every FDP becomes meaningful when we get to learn from experts who bring not only knowledge but also experience, insights, and inspiration. Today's speaker is one such distinguished personality. It is my honor to introduce Dr. Shatanik Mukherjee, a distinguished researcher whose work lies at the crossroads of biomechanics, mechanical engineering, and regenerative medicine. Dr. Mukherjee has been associated with the Department of Mechanical Engineering at Jadavpur University, the Department of Applied Mechanics at IIT Delhi, and the Biomechanics section at KU Leuven, Belgium. His research interests include regenerative medicine, cartilage mechanobiology, synthetic biology, system biology, multi-scale modeling, finite element analysis, and biomechanics. His interdisciplinary work aims to understand how mechanical and biological factors together drive tissue regeneration and repair. He has conducted several research projects and have been invited to speak at international conferences. His accomplishments have been recognized through awards such as the Rita Levi-Montalcini Postdoctorate Fellowship in Regenerative Medicine in 2025, the European Society of Biomechanics Students Awards, and many more. Dr. Mukherjee is also an active member of leading professional societies, including ESB, ORS, and VPHI. So please join me in welcoming Dr. Shatanik Mukherjee. Sir, I request you to start the session and proceed with the session.
Thank you very much for the nice introduction, Dr. Bose, and good evening, everyone. I'll first share my slides, and then we can proceed from there.
Sure, sir.
Could you please confirm if you can see my slide in the presentation mode?
Yes, we can see that, sir.
Perfect. Okay, then I will just begin. Good afternoon, good evening, everyone. I am Shatanik. I am Rita Levi-Montalcini postdoctoral fellow in regenerative medicine in the Washington University in St. Louis in the US. And today I'm going to talk to you about this broad interdisciplinarity in biomedical research, going from basic mechanics to mechanotherapeutics. And I will try to bring in what are the possible areas where deep learning methods are being used to basically facilitate research in these different directions. But before I delve deeper into that, I wanted to give you a very short introduction about myself. Dr. Bose had already given quite comprehensive, but I just wanted to show you the interdisciplinarity in my training that actually really helps in doing interdisciplinary research at the interface of mechanics and biology. So I did my undergraduate from mechanical engineering in Jadavpur University, and subsequently I moved to New Delhi to pursue my master's, where I was in the Department of Applied Mechanics. And it was during this time that I actually started getting interested more into application of mechanics into the human body. And then I was working on developing computer models to simulate the cutting of brain tissue using a cohesive zone approach. And with this interest, I then went on to pursue my PhD also in this field of application of mechanical principles and combining them with biology. And I made this move from India to Belgium to a city called Leuven, which hosts the University of Leuven, which is a 600-year-old university, is one of the oldest universities in Europe. And there I was working on developing computer models to understand cartilage and how cartilage responds to mechanical loading and how disease progression can happen and how disease progression like osteoarthritis happen in cartilage and how we can actually model them. So that was working in the interface of using mechanical based models, but also biology based models and combining them together. And subsequently, since 2025, I have relocated from after obtaining my PhD. I've relocated to US, specifically to Washington University, where I am working on cartilage regeneration, but specifically focusing on experimental synthetic biology-based approaches, which can be used to regenerate cartilage. And this is more from the experimental side of things. So that sort of is forms the background of myself going from a more mechanical engineer to applied mechanics to more computer modeling of mechanobiology, and now working more on really hardcore biology and synthetic biology, and combining my previous training with my present training together. So this forms a wide range of trainings that I have had over the course of time, and then that also gives me possibility to look into diseases from very different perspectives and solve them differently. And the disease that I'm going to talk about today, which will form sort of the basis of today's presentation, is osteoarthritis, which is a degenerative disease of the joints. And it affects multiple joints in the human body. The most commonly affected joint is the human knee joint. Uh, and what happens in osteoarthritis is degeneration of articular cartilage, which is the soft cushioning tissue that is present in between the articulating ends of the joints. As you can see, this white tissue that is the cartilage in a healthy knee of a patient is completely degraded in osteoarthritis. So you can see all these degradation of the cartilage in these locations indicated by the red circles. And what happens as a result of this is there's a lot of pain in a lot of patients, and there's a loss of mobility and loss of quality of life, and it's a global burden. And just talking about some numbers regarding osteoarthritis, it affects more than 500 million people worldwide. And it's a disease that generally increases its prevalence as people age. So with a global increase in population happening across the world, especially in the Western world, this is becoming more and more a bigger problem to deal with. And it's leading to a lot of loss of quality of life of patients, a lot of pain, and it has a huge economic burden on the society. And the problem with osteoarthritis is that osteoarthritis, there is no cure to osteoarthritis. Neither are there any disease-modifying drugs. So there is only pain management. So just taking medications to reduce pain for patients, or there is, as you will be aware of, doing joint replacement surgeries for these patients with knee osteoarthritis. But the problem with joint replacement is that it does not last for more than 10, 15 years. So imagine someone getting osteoarthritis at an earlier age might need to do joint replacement multiple times in their lives. And every time you do a joint replacement, the chances of getting infection and the chances of the joint replacement failing is also higher. So that creates a big problem of dealing with this disease. And that's why researchers have been working tirelessly to find out a possible solution to actually stop the progression of the disease and also try to regenerate cartilage in osteoarthritis when the cartilage is severely damaged. Now, talking of cartilage as one of the primary hallmarks of osteoarthritis, because this cartilage is degraded, we first need to, I wanted to give you a brief overview of what this articular cartilage that I'm talking about is made of, and that would help us in understanding why or what are the steps that we can take to actually preserve the cartilage and actually also in the long run regenerate cartilage if we want to. So cartilage, as I mentioned, is located in the articulating ends of joints, knee joint being one of the classical examples. So if you look at a cartilage in the human body, it's about uh, 3 to 5 millimeters thick. And it consists of multiple zones. If you look at the thickness from the surface, going deeper inside the bone, it has got multiple layers. So researchers have classified it into three main layers: a superficial zone, which is like close to the surface, then a middle zone, which is like below the superficial zone, and then there is a deep zone, which is close to the cartilage where it is attached to the bone. And cartilage consists of only one type of cells, which is also very unique, that it has only one type of cells in the tissue, and that is called chondrocytes. And chondrocytes have different morphologies. So these chondrocytes, which are close to the surface, they have like a very flattened morphology, whereas if you go deeper down, it sort of gets more circular, and then subsequently it becomes larger, and it has a more elongated profile. So that the cells themselves have different shapes at different locations across the thickness of the cartilage. Furthermore, it's a very intelligent material, the cartilage. So because, as you can imagine, when someone is walking or doing all the daily activities, it is getting mechanically loaded. And by nature, the design of cartilage is made in such a way, nature has designed cartilage in such a way that it can actually withstand these mechanical loads for millions of times all through the life course of a person. And one of the ways it does it is by the arrangement of collagen fibers inside the cartilage, which forms this arch-like structure. So the collagen fibers are like perpendicular to the bone cartilage interface, whereas on the surface of the cartilage, it sort of is parallel to the surface. And this gives the cartilage its very typical mechanical behavior, which helps in withstanding long-term mechanical loading. And the structure of these collagen fibers are very similar to the structure of arches that you would see in old buildings that is used to resist mechanical load. So that sort of arches are actually also mimicked in human cartilage to resist mechanical loading. So collagen is one of the main constituents of cartilage tissue, but it also has a lot of other matrix components that make up the cartilage tissue. Like cartilage is very rich in a protein called aggrecan, which sort of binds it together and gives it also gives mechanical properties to the cartilage, and a multiple of other matrix components. And this combination of the collagen fibers and the other matrix components give cartilage its very typical properties, mechanical properties, which actually helps in doing all the activities that we do and helps in smooth articulation of the joints. And if I just try to highlight some of these very typical properties of articular cartilage, one of the first things that is very striking is the cartilage has very low coefficient of friction. It's in the order of 0.002 to 0.01. And just to give you a comparison on how slippery cartilage is, a coefficient of friction of ice on ice. So if you have a block of ice slipping on another block of ice, as you can imagine, it's already very slippery, but cartilage is even one order of magnitude more slippery than that. So it's a very well-designed material that is very slippery, that enables smooth rotation and movements of the joints without causing any issues. And also the cartilage is very strong mechanically. It can withstand as you are walking or jumping or say walking up and down the stairs, it can absorb mechanical loads 2 to 6 times your body weight. For example, athletes who are doing like high jump and long jump, it can go up to 10 times their body weight. And the cartilage is strong enough in the knee to resist those very high loads. Also, the cartilage has very amazing fatigue properties. So imagine a lifetime of a person doing different activities, walking, running, jumping, and whatnot. And that means the cartilage is loaded more than 250 million times in the life cycle of a person. So it has this unique ability to resist any wear and tear, even being loaded for so many times, which you cannot even imagine happening to any artificial materials as such. And some other features, as I mentioned, cartilage has only one cell type, the chondrocytes. And another particular feature of cartilage, which is very unique to cartilage as compared to all the other tissues in our bodies, is that cartilage does not have any nerves, neither does it have any blood vessels. So it's a neural and a vascular tissue. And because it doesn't have any blood vessels, it is very difficult for cartilage to regrow itself. So if a cartilage is damaged by, say, a shock or a trauma, or in osteoarthritis, it is very difficult for cartilage to heal on its own. And that's why it's also a very difficult case of solving cartilage degeneration as compared to, say, your bone, which if you have a fracture, it really heals very easily for most of the cases without even leaving a scar. But cartilage does not heal because it's avascular in nature. And with this very interesting basic facts about our cartilage, I would like to highlight how the disease osteoarthritis is a multifactorial disease. And even though it's seen as an endpoint is the wear and tear of cartilage and pain, but the way it progresses is not one particular factor, but it is dependent on a combination of many factors. And the reason I say this is because if we think of the disease as a multifactorial disease, it means that to treat the disease, we'll have to also understand these different factors and the interdisciplinarity involved in understanding these different factors. And just to give you an example of this, so if you go to a mechanical engineer and ask, especially a biomechanical engineer, and ask what could be the possible cause for a damaged cartilage, mechanical engineer would say it is because of mechanical overloading. So if you are overweight, or if you are, for example, have loaded your joints more than normal for doing, like, say, sports related activities that have induced trauma in the joints, so that can cause cartilage damage. And this is more coming from a cartilage damage being a very wear and tear disease. But if you go to biologists would say cartilage damage can happen due to many other factors, like inflammation in the joints, like metabolic factors, like genetic predisposition. So if you are prone to having osteoarthritis because of genetic predisposition, so all these different biological factors a biologist will cite. And if you go to a clinician has nothing to do but to operate on these joints, because there is no existing drugs or treatments to cure osteoarthritis. So that sort of shows how multifactorial this disease is, and this involves a complex interplay of different factors that leads to its progression. So at the same time, osteoarthritis is a multi-scale disease, which means that, say, for example, if there is a global change in the tissue properties, that would basically change the behavior of these individual cells that are there in the cartilage. And this goes back and forth in a feedback loop to lead to the progression of the disease and cartilage damage and pain and all those factors that is involved. So if we want to understand this progression of osteoarthritis in our joints, specifically focusing, say, on the human knee joint, we must need to understand the multifactorial and multi-scale aspects of the disease. And one of the ways people have tried to look at, and this is what I have also looked at during the course of my research, both during my PhD and now also in my postdoctoral fellowship, is looking at it from a multi-scale perspective, going from a patient level, saying how the patient walks and how the gait of the patient is different in osteoarthritis, and then subsequently going down the scales to looking at the individual joint that is under focus, looking at the corresponding articular cartilage in the tissue level, and then further zooming in into individual cells in the setup in the joint, and see how the cells are behaving, and further zooming in into the intracellular behavior. For example, if the cells are predisposed to osteoarthritis, if there is some change in the intracellular signaling for these cells that actually causes osteoarthritis. So there's this wide range of possibilities across the different length scales, going from a patient level to an intracellular level, that needs to be studied comprehensively to understand osteoarthritis and to find strategies to arrest the progression of osteoarthritis. And this is what is going to form the basis for the next section of what I'm going to discuss with you. I'll go scale by scale, going from patient to organ tissue, and then subsequently cell and intracellular. And I will try to give you examples of research in this field, which involves the use of machine learning approaches as well to facilitate some of the handling of data and to infer from the data, and how these different length scales are tackled and how they are being studied in a very interdisciplinary manner to understand osteoarthritis and to find therapeutic strategies to arrest osteoarthritis. So first scale for us is the patient scale. So in the patient scale, imagine a patient having osteoarthritis or having knee pain, goes to the clinic, and what are the possible things that can be done with the patient from a research perspective, but also taking it closer to the clinics to basically already detect very early in the patient if the patient has osteoarthritis, or what if the patient already has osteoarthritis, what can be done in the patient level. So one of the things that has been traditionally done in this patient level models is to do gait analysis of the patients. So basically to do the analysis of how the patient walks and to see if there are any anomalies in the gait of the patient that might be the precursor to osteoarthritis in one case, or if there is already some anomalies that has caused osteoarthritis, try to say correct the gait of the patient so that now the patient is walking in a proper manner that will stop the disease from progressing further. And the way gait analysis is traditionally done used to be traditionally done in research laboratories and sometimes in some advanced clinical practices was what is called a marker-based gait analysis. So what would be done is a patient, if the patient goes to a gait analysis lab, there would be these reflective markers placed on the body of the patients. And then the patient would be allowed to do different daily activities like walking or running or jumping. And then by means of multiple cameras and force plates, the markers placed on the patient's body would be tracked, and subsequently the motion of the patient's gait and the forces will be calculated. Just to give you an example of how it works, so there are these biomarkers placed on the patient's body, and the patient is walking with cameras tracking the motion of the patients. And then also the patient walks on these two force plates, which have basically force sensors that senses how much force the patient is putting on the force plate while the patient is walking. And then subsequently, by using a set of models which are called musculoskeletal models, the gait analysis can be done, which is basically going to give us information about the different rotations and the translations of the different regions of the joint, and also the forces that acts on the joint during the walking of the patient or some other activities. And this gives us idea as to if there is already some anomalies in the gait of the patient, the way the patient walks, that might be a precursor to osteoarthritis, and that can be corrected. Now, one of the issues with using these markers on human body and doing the gait analysis subsequently is that these markers are it's very time consuming, firstly, to put the markers on the human body, and it also is intrusive because once you put markers on the body of a patient, the patient becomes conscious and sort of does not walk exactly in the same natural way once there are some markers placed in the body. So there might be some anomalies in the measurement of the gait of patients when markers are placed, just because the patient becomes conscious of it and does not follow the natural gait pattern and might try to compensate or do something that might hinder some of the inferences that you actually want. So the field has gradually moved on from marker-based gait analysis to more marker-less gait analysis, so which does not involve use of markers, but it uses basically different computer vision approaches and deep learning approaches to basically infer the gait of the patient just from videos or images captured from multiple cameras. And because it does not involve uses of markers and fixing of these markers and calibration, so it's comparatively faster than a marker-based approach. However, some of these markerless approaches, which basically tracks the markers and infers the gait of the patient from tracking these markers using deep learning methods, have some disadvantages. One of them being that they are less accurate sometimes, and to get more accuracy, it requires more number of cameras at different angles to track the motion of the patient. So sometimes it can be 5 to 7, or even going up higher to 10 cameras that might be required to actually very accurately track the motion of the gait for a markerless approach, which might also be a sort of a bottleneck if you're trying to use it in the clinics. And therefore, researchers in this field of musculoskeletal modeling have now made big advancement in this regard. And this has been facilitated by the use of AI-based approaches. And one of this is a model which is called OpenCap, which was developed by researchers from Stanford. And they have now made it possible to track the gait of patients from, instead of using very fancy cameras, but just by using two mobile phones, two iPhones and an app. And I just wanted to highlight this advancement. So you can use two iPhones to basically capture a video of a patient, and then this software OpenCap uses AI-based tools to basically, from the video, track the motion of the part of the person. So by looking at the different anatomical regions of the person, it would use these AI-based models to basically, from the videos, get into a musculoskeletal model like this that tracks the rotations and the translations of the different regions of the joint. And then they have combined it with a musculoskeletal model to basically, from using a couple of mobile phone videos to tracking the gait of the patient. So as you can imagine, this has been a paradigm shift, that just by using two simple phones, you can track the gait of the patient. And this has sort of made a shift in the field to, instead of using very fancy and very expensive cameras, to just two mobile phones to track the gait of the patients and see what are the anomalies in the gait that you can correct in the future. And just to give you a sense of how much improvement that has been over in terms of the amount of effort and time and money that is required. So one of these typical marker-based approaches of gait analysis would involve multiple cameras and force plates, which are already more than $1,000. And then it would take quite some time to basically first put the markers in these patients and then do the data collection. And then once you do the data collection for the patients, it requires quite some time to post-process that data by manually looking at the data and removing any noise and error and fitting it to a musculoskeletal model like the one that you have on the right. So the whole process from a patient arriving at the gait analysis lab to getting a detailed information about the gait of the patient would take more than a day. Previously, we using marker-based analysis, but now with OpenCap, with this video-based motion analysis, you can basically get the whole thing done in a matter of 10 to 15 minutes. And the cost of doing it is also significantly reduced. You just need a couple of phones, properly having a good video recording capacity, and just a couple of tripods. And the whole setup is like 5 minutes, a couple of minutes of data collection. And basically, after the data is collected, it uses a set of deep learning based approaches to infer the gait of the patient from the videos. So it goes on really fast. And it's one of these paradigms which is very efficient in looking at the gait of the patient and looking at gait of patients, say a healthy patient versus an osteoarthritic patient, and see how the gait has changed, how the walking pattern has changed for the patients. And that gives us idea of how you can actually approach the patient and say suggest possible gait corrections from a more physiotherapy standpoint to suggest gait corrections that can actually stop osteoarthritis from progressing. Another approach that people have taken with using these gait data is basically, if you is some pre-trained machine learning algorithms that have been used to to basically predict whether someone is going to have osteoarthritis, in this case, hip osteoarthritis. If we just look at the gait data from a patient, so based on one of these approaches that I described, and you can use these machine learning algorithms to predict whether in the long run these patients will have say osteoarthritis. And these can be very handy black box based models which would just record gait of patients and give an idea to the clinicians that this patient might possibly develop osteoarthritis, and then the clinician can figure out what could be the possible corrections in the gait that can be done to basically stop that from happening. So this factor of measuring gait of patients and how AI is being used, not only in measuring the gait of the patients, but also to predict from the gait of the patients how a disease might progress over a long run. And then that gives clinicians ideas and opportunities to do an early intervention before the disease has progressed to a later stages. So that was all from the patient side of things, how gait analysis can be used and how AI-based approaches are being used to basically measure gait and make predictions about diseases. Now, the next part, I would try to focus more on the organ and the tissue level. So the organ level in our case is basically the human knee joint, and the tissue level consists of the different tissues in the human knee joint, primarily the articular cartilage, which is this primarily affected in osteoarthritis. So if we zoom in, one of the areas where in the joint and tissue level there has been considerable work is to look at MRI images of the joint and try to see if from the MRI images there is already visible cues, as in terms of already from the MRI images, you can see that there is loss of cartilage happening at certain regions. So cartilage is one of these tissues that you generally don't see in X-rays. So you need MRI images to basically look at cartilage. So doctors, in order to diagnose osteoarthritis, would basically do MRI scans of the knees or in other joints, and then try to look in these slices of MRI images to see if there is loss of cartilage in some regions, and or there are some other factors like some additional bone growth and things like that that are markers of osteoarthritis. But you can imagine this whole process of generating the MRI and then looking at the MRI scans is also very subjective and time consuming, and therefore the field has moved into using AI-based tools to basically segment these tissues out from MRI images. So this is all about using different deep learning based image segmentation approaches that have been used to segment these different tissues, especially the articular cartilage, from MRI images. And the reason that it is useful is by using these deep learning algorithms, you can not only segment the cartilage from the MRI images, but you can also classify them into different regions, as you can see in this schematic figure. And then you can look at these different regions in the cartilage already that is segmented by using these deep learning algorithm approaches to look for regions where there is, say, changes in the volume of the cartilage or the changes in average thickness and things like that, looking at all these morphological features. And this can already give us a very early detection of osteoarthritis in terms of changes that happen in the cartilage morphology that probably could not be actually detected by a human eye, but these deep learning tools can actually segment and classify these different changes that happens in the cartilage. So from the image segmentation of MRI images, there has been huge progress in these algorithms to do the image segmentation from MRI images. So not only is it useful to basically segment the images and infer about changes in morphology, but some of the recent research in this field has also looked into combining these inferences from the images, but also informing these deep learning methods with other clinical factors. Say, for example, if what is the age of the particular patient, what is the BMI of the particular patient, if the patient already has had some joint trauma or joint injury, and all these clinical factors can also be incorporated in the deep learning framework together with the image segmentation and looking at the morphology of the from the segmented images to basically predict what are the possible chances of osteoarthritis happening in a particular patient. And you can see this example where uh, uh, on the top row you will see that there are different MRI scans from the patient, and on the bottom row with this contour plots showing what are the regions that these deep learning approaches actually predicts where there is possible cartilage loss happening. And prediction is based on not only looking at the MRI images, but also incorporating other factors, as I mentioned, clinical factors like age and BMI and predisposition to injury and all those stuff. And these deep learning tools does quite a good job in locating those regions where you would expect possible cartilage damage. In the case A and D, it's basically in this region around the patellofemoral region, which is basically the region where your patella is meeting your femoral cartilage. In the case B, it's basically in this tibiofemoral region, also in the meniscus, which is a tissue in between your tibia and femur, which are these two opposing ends in the knee joint. It has also predicted changes in the region called intrapatellar fat pad, and how changes there, which is almost very difficult to basically look at from the naked eye. But these deep learning tools can actually detect these changes and predict possible cartilage damage in these regions. But also there has been some other regions where it falsely predicts. So there are always going to be false positives and false negatives, and it's also upon the discretion of the person using these tools to be aware of them. So this gives you an idea that these it's not only image segmentation from MRI images that can be helpful using deep learning approaches, but also combining this image segmentation with other clinical markers that can be used to basically predict the progression of osteoarthritis using deep learning approaches. So this is one way of looking at these approaches. The other field where image segmentation has been widely used is to develop what is known as finite element models. So these are physics-based models which can be used to look at the distribution of forces and stresses and strains in the different regions of the joint. And this can provide information about how the joint and the different tissues in the joint are mechanically loaded. And then we can infer from those information how we can expect a disease to progress in these cases. So what is typically done in developing a finite element model is, firstly, you start off with the MRI scans, and then you use one would use image segmentation algorithms, some of what I discussed before, to basically segment the different tissues, specifically the cartilage and the meniscus, from these MRI images. And once you have these segmented tissues, then you use finite element approaches to basically convert this into a mathematical model, convert the geometry into a mathematical model, and solve this mathematical model using a principle of finite element analysis to look at the distribution of mechanics in these. And just to give you an example, this is work from my doctoral thesis, where we developed a finite element model of the human knee joint from MRI images. And then these finite element models, which are basically physics-based models, can be fed with gait data. So we used gait data from previous studies where they have looked into the gait of the patient. And then you can use these data to simulate this knee joint. And simulating this knee joint in using a computer model can give us ideas how, when a person is walking, there is distribution of stresses and strains in the articular cartilage, as you can see in the articular cartilage figure here. So this gives us idea of how the stresses are distributed when someone is walking or doing some other activity. And by using these finite element models, then you can basically get an idea if the person is overloading the joint and the cartilage, and what are the possible gate corrections that you can do to basically stop the joint from getting overloaded. Some other applications that you can think of using these finite element based models is, say, look at a pathological case and see if that pathological case is biomechanically responsible for increasing stresses and strains in the cartilage that might lead to the progression of a disease. So one of the case studies that we did in my research is looking at a pathological case of meniscectomy. So meniscus is this in the healthy knee. You see this red tissue in between the femoral cartilage and the tibial cartilage in the knee. And it's a cushioning tissue that provides a sort of cushion between the femur and the tibia. And what happens in a lot of sports-related injuries, especially for a sports person, is this meniscus gets damaged, and then are sometimes, if it is damaged beyond repair, doctors would basically take the meniscus out, and that surgery is called a meniscectomy. And it has been seen that meniscectomy causes osteoarthritis. So patients which have meniscectomy will develop osteoarthritis in, say, 10, 15 years from now. And we wanted to use these finite element models to actually see what is changing biomechanically. That might be actually the reason for this long-term development of osteoarthritis. And we simulated this meniscectomy in our finite element models by removing the menisci from these models. And as you can see with the meniscectomized joint, you will see that with this contour plots showing the distribution of stresses and strains, you'll see that as you remove the meniscus, the cartilage, especially the tibial cartilage, you will see that there is a lot of increased stresses in the cartilage, because now the meniscus is not there. There is no cushioning effect of the meniscus, and then that leads to higher stresses. And this could be potential regions where you could see subsequent damage of cartilage happening in the long run. So this is an example to show that finite element models, which are more physics-based than data-driven models, can also be used to possibly predict what are the regions of cartilage where a patient might encounter cartilage damage, and subsequently do this much earlier in the form of a predictive model that can help in early detection of osteoarthritis, and make the patient walk in different ways so that you can stop this from happening, or find some other possible therapeutic regimes to stop the overloading of the joints. So that was more from the organ and tissue level that I wanted to discuss about, looking at how the different tissues in the joint, especially the articular cartilage, is looked into from image segmentation, and then subsequently using finite element based approaches to calculate the stresses and strains in the articular cartilage, and look into how you can use those information to predict progression of osteoarthritis and cartilage damage. Now I'd like to shift gears and go more detailed into the cellular level and the intracellular pathways and the intracellular processes, biochemical processes that are triggered as a result of changes in the cellular level. And I would like to highlight some of the current research that is happening in the field to basically use individual cells and use intracellular behavior to basically regrow cartilage. So till this point, we talked about how we can use computer models, either deep learning based approaches or more physics based finite element approaches to predict disease progression. The next part would be more how, once the disease has progressed, how we can use cells and intracellular signaling to basically regrow cartilage. And this concept of regrowing tissue from cells of the human body is called tissue engineering, where the typical paradigm for tissue engineering is you take you isolate some cells from the human body. It could either be stem cells or it could be uh, the particular cells of interest. For example, if you're trying to regenerate cartilage, you can just slice out a section of the cartilage from an unloaded region in your joint, or just try to collect a few cells. And then once you isolate the cells from the human body, ideally what is done is then there is a cell expansion step where you would basically, from a finite number of cells that you collect from the patient, you'd want to you want to multiply the number of cells so that you have considerable amount of cells. And then what is done is these cells, whether it is chondrocyte or some of stem cells, that can then differentiate to chondrocytes. So these cells, after they are expanded, are basically then seeded in what is called as a scaffold. So a scaffold is basically a structure where you embed the cells, and it basically gives mechanical support to the cells to start regenerating its own matrix. And once you seed the cells in the scaffold, one would put these cell-seeded scaffolds in the medium in devices called bioreactors, where you would put growth factors, which are basically factors that would stimulate the cell to create artificial matrix and create an artificial tissue in the long run. And then you would put different culture conditions that would enable the cells to secrete their own matrix with the long run generation of new tissue, but happening outside the body. And once the cells have already secreted subsequent amount of matrix, so that the scaffold is now filled with matrix and it resembles close to the properties of a tissue of interest, for our case, cartilage, then these cell-seeded scaffolds, which are now called tissue constructs, are implanted back into the human body, especially in the defect where you have a loss of cartilage. And basically, this tissue engineering approach is using your own cells to regrow your own tissue and regenerate your own tissue using a combination of cells and a scaffold, which is a biomaterial, and some growth factors. Now, this has gained subsequent interest in last 20, 30 years, especially because this is one of the, how would I say, it's a way in which you can regenerate your tissue without needing any joint replacement surgery. So you can use your own cells to regenerate cartilage. And it is very true for cartilage, because cartilage is one of those tissues in the human body which does not regenerate on its own. So tissue engineering approaches are very much being studied and tried to be translated towards the clinics to basically regrow cartilage. Now, as you can imagine, that this is a very complex process, going from cell isolation to the tissue development and back to inflammation, back to implantation in the joint, and in these different steps of this tissue engineering processes, there has been a lot of use of computer-based models to actually help these different processes. So I'll try to focus on a few examples here in the paradigm of tissue engineering where models have been used, though these are more going to be physics-based models. So one of the areas where computer models have been used is to design scaffolds for tissue engineering approaches. So this is an example of previous studies from our group, which designed different scaffolds for bone regeneration. So if you have a bone defect, how would you design a scaffold that when you put cells in the scaffold and put it back in the bone, in the defect region, how would it regenerate cartilage? And this involves computer models with a background of mathematical models that model the flow, the mechanics of the scaffolds, but also how this mechanics influences tissue growth in the scaffolds. And by using these computer-based approaches, you can actually try out many different designs of the scaffolds and many different conditions and many different external conditions to see which of the design is the best suited to regrow cartilage or to regrow bone. And this is all being done in the computational domain. which means that it is much faster and it's much cost efficient. So what people in this field have done is use this in silico modeling techniques that would first optimize a design of the scaffold in the computational domain and then test the optimized design in vitro in experimental scenarios to basically validate the optimized design. And that sort of reduces a lot of the trial and error experiments that you need to do to get a particular design of scaffold for tissue engineering. And this is a field where recently that instead of using more physics-based approaches, which look at the mechanics and the tissue growth, more data-driven approaches are also being used to design an optimal scaffold that would help in the tissue engineering process. So we talked about the use of computer modeling, both physics-based and deep learning to design scaffolds for tissue engineering. Now, the other thing that I want to also highlight the fact that this whole paradigm of tissue engineering of, growing cartilage and then putting it back into the human joint, it has its restrictions of doing in vivo experiments. So there are limitations on what you can do in vivo in terms of what are the controls that you have and how you can control the different parameters in the patient itself. And it is very difficult to get approvals to try these therapies out in patients unless you have already shown it out in vitro and in small animals. And to facilitate this testing out of these different scaffolds and these different types of cells and growth factors outside the human body, there has been a considerable amount of research in the last 15 years to look into what are called microphysiological systems, which is basically a miniaturized version of the knee joint. And microphysiological systems have been developed for different organs. There are microphysiological systems for, say, the human brain, the lung, the heart. There are also microphysiological systems for cartilage, which are called cartilage on chip. So these are basically microfluidic devices that are in the scale of a couple of millimeters, so really small, as you see here. But what these devices do is you can put these cartilage cells that we discussed that you would want to use for tissue engineering in these devices and basically mechanically load these cells in a similar way that you would do in a human knee joint, but in a much more controlled fashion and in a much more miniaturized, small-scale version of mimicking the human knee joint. So this cartilage on chip setup, I had the privilege of working with one of these cartilage on chip setups during a collaboration with the University of Twente in the Netherlands, where they have developed this cartilage on chip device, which has like 3 pneumatically actuated chambers, and then by varying pressure in these chambers, you can create a complex loading of the cells that are underneath the membrane in this setup to create a complex mechanical loading which mimics the mechanical loading of cells that are experienced in the human knee joint. And this basically is a miniaturized version of a human knee joint, which gives us more control in looking at individual cells and study them and see how mechanical loading can affect these cells in terms of matrix production and use these information to basically govern tissue engineering strategies. So some analysis that have been done in this regard is using these cartilage on chip devices. People, and this is work that I did during course of my PhD, is also looking at a multi-scale fashion. So you can look at the cartilage on chip device with cells inside in the device and look at what happens to the different regions of this device if you load them, and then compare that with computer models to see how your model predicts in terms of mechanics being imposed in these devices. But you can also zoom in, and using microscopy techniques, you can zoom in these cartilage on chip devices and look at individual cells and basically compress use the compression in the devices to compress individual cells and basically compare them to models to see how individual cells are being compressed in this device. And that gives us idea of how your cells get actually compressed when you put them back in the human knee joint, for example. And you can also one can also do long-term studies of putting mechanical loading to cells in this setup and look at, say, how these cells individually would secrete matrix proteins that would enable the regeneration of tissue in the long run. So these cartilage on chip microfluidic devices gives us this possibility to study in a very multi-scale manner from the device level to the intracellular processes that are triggered in these cells when you put mechanics in them. And these are possible in a much more controlled manner that is very difficult to do in a human joint in vivo. So use of microphysiological systems has therefore been a very potent progress in this regard to basically form a small scale model of a particular joint or a particular organ, and that gives us a lot of possibilities to study not only joint diseases but also to study effective therapies for regeneration of cartilage. Now, one last application that I want to highlight here. So we talked about the whole tissue engineering paradigm, which uses cells from the human body to regrow tissue outside the body and implant it back into the human body. But in the context of cartilage regeneration, especially in osteoarthritis, what happens is when you implant these tissue engineered cartilage back into the osteoarthritic joint, what happens is that because there is this high load and high inflammation in these joints, a lot of these tissue engineering strategies do not work very well because these high mechanical load and high inflammatory environment actually starts killing the cells that you are implanting back in the defect joint. So researchers have tried to find out what could be possible solutions to basically alleviate this problem of cell death and catabolic processes triggered when you are trying to do tissue engineering of cartilage. And one of the very recent progresses in the field has been in the direction of synthetic biology, which has enabled researchers to basically edit the genome of these chondrocytes so that the chondrocytes are more resistant to mechanical signals. And one of these ideas that have been explored, and this is part of my postdoctoral work that I'm doing here at the Washington University, is creating smart cells using synthetic biology tools so that these cells, when they sense these abnormal mechanical loading in the joints, they would secrete their own drug that is going to basically stimulate the production of cartilage. So you can imagine this like as a smart cell being like your smartphone with a force sensitive touch sensor. So these smart cells are like your smartphone that can sense forces, and then they can respond to these forces with a particular drug. In our cases, we are trying out different drugs, for example, dynorphin and some blockers of inflammation. And what we are effectively trying to do in this case is we are using synthetic biology techniques to create synthetic gene circuits inside these cells so that when the cell senses a mechanical load through one of its mechanosensors, it basically is going to trigger the synthetic gene circuits to produce a drug of interest. And this is basically autonomous system that just like your smartphone that senses your touch and then you can do all the different things with it. So the smart cells form an autonomous system that responds to mechanical stimuli and creates its own drug. So what is done now is using these smart cells, now they are transplanted back into the knee joint, and when you are transplanting it back into an osteoarthritic knee joint with all the abnormal mechanics that these cells sense, the synthetic gene circuits are triggered, and that leads to triggering of these anabolic factors that actually arrest cell death and triggers cartilage regeneration. So this autonomous system of using mechanics to trigger cell to produce their own matrix is a new, very new field called mechanogenetics, which combines mechanical loading in the cells with synthetic biology techniques to edit the genome of the cells to lead to basically regenerate cartilage. So this is one of the very emerging field of research that's very multidisciplinary and very forward-looking that would develop a lot in the next few years for cartilage regeneration strategies. So with this, I'm going to conclude today's talk. I would just like to highlight the things that we discussed. So I tried to bring this whole perspective of multi-scale approaches to understand and to provide therapeutic strategies for osteoarthritis, going from a patient level to intracellular, and how you can change the intracellular behavior of cells using synthetic biology techniques. So in the patient level applications, we discussed how we can use deep learning based algorithms to do gait analysis of patients and look at osteoarthritic prediction with other clinical markers and the gait of the patient. In the organ and tissue level, we looked at how deep learning based methods are being used for segmentation of the different tissues in the joint from MRI scans, and how they can be used for osteoarthritis predictions, but also use of finite element based approaches that can be used to basically measure the biomechanics of these joints and predict osteoarthritis in the long run. And then in the cell and the intercellular levels, I talked about the tissue engineering paradigm, which is used to regrow articular cartilage in the joints. And then I talked about how we can use computer-based models, both physics-based and data-driven, to design scaffolds for these tissue engineering strategies. I also talked about how you can make a small scale version of your joint using a microphysiological system called a cartilage on chip device. And subsequently, I also talked about how you can use synthetic biology techniques, especially techniques like CRISPR, to basically edit the genome of these cells to create smart cells that would basically get activated by abnormal forces and trigger regeneration when they are implanted in the defect region of an osteoarthritic joint. So that brings me to the end of the presentation, looking at the different applications in the context of osteoarthritis. I'd like to acknowledge funding from multiple different sources that helps us do the research that we do in these laboratories. And I'd like to thank you for your attention, and I'll be happy to answer all your questions. Thank you very much.
Yes, sir. Thank you. We will look into some questions that we might get. So we are waiting for that. Still now, I cannot see any questions.
Hand raise.
So is there any question?
Deepak, hand raise আছে।
Please put your questions in the chat box. Yes, I have got the question from Dr. Shomadip Ghosh. What is the role of regenerative medicine and orthobiologics in the interdisciplinary management of osteoarthritis, and how do mechanical factors play a part? So
thank you for the question.
This?
Yeah, of course. So that's a very good question, and osteoarthritis and regenerative medicine are very intricately linked. So in the context of regenerative medicine, we are basically trying to regenerate a particular tissue of interest, and in our case, it's cartilage, because that's the joint that's the tissue is most affected in osteoarthritis. And is something that does not heal on its own. So that highlights the important regenerative medicine for osteoarthritis, because these, as we know, these joint replacement surgeries, which is the other alternative, is not a sustainable process, because every 10 to 15 years, you need to replace the joint, whereas regenerative medicine is more about creating your own tissue from your own cells, and that is much more sustainable long term. So that's the relevance of regenerative medicine from an osteoarthritic scenario, and then answering the question of how mechanical factors are important. So in the context of osteoarthritis and cartilage regeneration, as you can imagine, the cartilage is one of the most heavily mechanically loaded joints in our human body. And these cells which are in cartilage called the chondrocytes. Sorry. Okay, so these cells, they are also, there has been a lot of research in this field looking at these cells and how they respond to mechanical stimuli, and they are very sensitive to mechanical stimuli, these cartilage cells. So both from a perspective of disease progression, it has been seen that abnormal mechanics, so for example, if you have a sports-related traumatic injury to your joints, that's basically abnormal mechanics to your joints and to your cells subsequently, that basically triggers the cells to start secreting catabolic factors that causes the disease. So mechanics influences how the disease would progress. At the same time, for cartilage regeneration as well, it has been shown that optimum mechanical signals need to be put to the cartilage to regenerate cartilage. So mechanics is involved both in cartilage damage with abnormal high amount of mechanics, but also optimum mechanics is needed for cartilage regeneration. So that's how mechanics is involved in osteoarthritis and regenerative medicine.
So we have another question from Professor Deepa Shaha Sarkar. She will ask you the question.
Thank you, ma'am. So first of all, thank you for this informative session. Like I have a question in the sense like robotic surgery is now for the last 2-3 years quite prevalent one in the knee replacement. So how is this like how to understand from the patient perspective whether to go for a robotic surgery or to go for the conventional method of knee replacement?
That's a good question. Robotic surgery is something that I didn't cover as much in this talk, but so there are different aspects of robotic surgery. So one of the reasons that people look for robotic surgeries is the precision in which you can do a surgery. So more and more emphasis is being placed on robotic surgeries because it's trying to minimize the invasiveness of the joint replacements, and compared to a whole open joint operation, which takes a longer time to basically heal. A more precise robotic surgery can be useful in that regard, that it's minimally invasive in that context, and that's one of the reasons that robotic surgeries are getting more and more popular. But there are also challenges to robotic surgeries as well, because you need very specific first of all, the cost in developing these robot assisted surgical tools are quite high, and robotic surgery is more used in cases where there is fine precision involved. For example, in brain surgeries and in some cardiovascular applications as well. But in orthopedic applications, generally there is the level of precision required is comparatively less. So that's why the field still is more focused on open knee surgeries compared to robotic surgeries. But it is going to be more popular over time because of the minimal invasiveness of these surgeries.
Thank you, sir.
Yeah.
Thank you, sir. We have another question from Professor Sheha Ghosh Dostidar.
Yes, please.
How to manage the spiking of tibial spines of osteoarthritis patient?
Could you review what was tibial spikes? Can you please repeat the question? I didn't get the last part.
Yes. How to manage the spiking of tibial spines of a osteoarthritis patient.
Okay. Yeah. So if I understand correctly, it's the question is related to how you get these bone growths in the tibial cartilage and these osteophytes formation in the tibial cartilage, and that sort of causes a lot of pain in the patients, and how to manage that. So that's a very difficult thing to manage, especially because when you start seeing these tibial spurs and these osteophytes start forming, it's comparatively at a later stages of the disease. And one of the ways of from a clinical perspective, from early detection, uh, you would ideally want to detect those formations quite early, and that's where all these image segmentation approaches that I discussed could be really handy. And if it gets translated to the clinics, which it will in the next few years, what you will see is that at very early stages of the disease, you can detect these tibial osteophyte formations and cartilage loss and bone spur formations from the MRI scans. And then to manage it, there are multiple possible avenues of research that is going on. One of them is more from the perspective of gait correction strategies. So where you would try to correct the gait of the patient so that you're not overloading that region of the tibial plateau where you would see possible damage to the tibial cartilage and this bone formation. So gait correction can be one of the ways. There are also other therapeutic approaches that are now looking into, say, how you can stop bone growth and abnormal bone growth into the cartilage by using some biochemical factors that would basically stop these bone osteophyte formations. And one of the research that we are doing in our lab is looking at an opioid called dynorphin, which we have seen some early studies in the group very recently, that actually this biochemical dynorphin can actually protect some of these bone osteophyte formations in the tibial plateau. We have looked into these in mice, and now they are being planned for the next phase of trials. So these are some of the ways you can tackle this problem.
So no more questions till now. I would request the attendees if there are any questions. Sir is here, so that can be asked. So let's come to an end to it. As we come to the end of today's session, I extend my heartfelt gratitude to the distinguished resource person, Dr. Shatanik Mukherjee, and for his insightful presentation, deep expertise, and engaging delivery on osteoarthritis therapeutic strategies involved, and your in-depth discussion on marker-based gait analysis to OpenCap, and your elaboration of smart cells and its usage. So it was really helpful for all of us, I believe. I also take this moment to thank all the participants for their active involvement and thoughtful engagement throughout the program. Once again, thank you, sir. Thank you, Dr. Mukherjee, for being with us today and making this session a truly impactful one. With that, we would formally bring the session to a close. So thank you all and good night.
Thank you very much for the opportunity, and have a good night, everyone.
Good night.